Okay. Okay, this meeting is being recorded. Okay, I'm gonna share my screen. So you guys are almost done CVP. How do you feel so far? How is the block? Someone private messaged me saying they want to die. Is it that bad? Okay. Okay. In my experience, POD was the most fair. POD, Bismillah. CVP was the most fair exam we had in third year. I'm not saying the other ones are going to be absolute hell on earth. They're not going to be bad, but it was the most fair in terms of like distribution and in terms of like the level of questions they were asking. And it was my favorite block personally. And the Pulmo, I used to hate it in first year, but I actually started, like, I loved it in CVP in third year. Okay, guys, okay, sorry about my camera quality. It's a 2013 MacBook, okay, and it's met like every environmental stress in the world, okay. Number two, if you can't hear me at any time, let me know. Number three, stop me anytime for questions, and please interact, okay, because obviously it's for you. I want you guys to be answering the questions and for us to discuss it and everything. And yeah, okay, I'm gonna start now. Okay, so do you guys have anything before we start? Like, do you guys want to say anything or get anything out of the way? All right, I'm gonna take that as a no, so we're gonna start. Okay. Just give me 1 second, guys. I get kind of confused because let me just minimize you guys and put you in the corner. All right. Okay. So, welcome to the Pulmonary review for CVP. We're going to be going through practice questions. I took all of them from Amboss. And the reason I did that and not take one from UWorld is because the Amboss ones are typically a little bit more challenging. They have more details that can throw you off. So I wanted to get you guys into the practice of really doing, like getting used to that and whatnot, so that when you see the questions, you don't freak out. Like when you see them in UWorld and stuff, okay? So I asked a few third years, like in person, I asked on Twitter, like, what do you guys want to focus on? One common thing that I heard was pneumonia and like infections, differentiating between the different like etiologies, treatments, kind of how to differentiate, and then it also in between the different interstitial lung diseases. I get that one is a little bit difficult, but we'll go through that today. And generally just differentiating, like, for example, if you have a question and it's a person who's coughing and you're just like, what the hell is going on with this person? I don't know if it's COPD. I don't know if it's interstitial. I don't know if it's congestive heart failure. It could be any of the above. We're going to practice that today, okay? So I have I have a few topic questions, like topic specific. So we're going to start with respiratory infections, and we're going to go into like restrictive, then obstructive, and then other topics, meaning basically lung tumors. And then I'm going to go into general. So it's going to be a mix of everything that you've kind of taken in Pulmo, and then we're going to go into it basically without you guys knowing, like, before which section is this from, because I want you guys to practice getting to a differential, okay? And then throughout, we're going to do concept review. I'm going to share a few things with you, and then I hope by the end you'll know what to focus on in the next 4 days before your upcoming final. But hopefully this will kind of give you like a guiding path into how to answer. Okay, so let's just like get into it. So by topic, we're going to start with respiratory infections and pneumonia. Okay, so does anybody want to read out loud, or do you want me to read? I would prefer if one of you guys read. If you really don't want to, I can read it, but I want to make sure that you guys are like following and stuff. I'll read it. Okay. Appetite for the past week. During the same period, he has been coughing up small amounts of malodorous phlegm. During the past 2 nights, he has had night sweats. He was diagnosed with HIV infection 5 years ago. He has hypertension, type 2 diabetes, severe heartburn. He's homeless. He does not take any medication. He has smoked a pack of cigarettes daily for the last 30 years. He drinks 8 to 10 beers daily. Temperature is 38.9, pulse 101, respirations 25 per minute. Blood pressure is 145/92, so he's slightly hypertensive. Patient appears intoxicated. Physical examination shows crackles and dullness to percussion at the right lung base. What do we know so far in this question? What is important to note, basically? Open the chat. Okay, cool. He's an alcoholic, coughing sputum. Good. Okay. History of drinking. Good. Okay. These are, I think, the most important things so far. Sure, he has a lot of other problems, but those were important to note. Crackles and dullness to percussion. Immunocompromised, yeah. At the right lung base. Scattered expiratory wheezing is heard throughout both lung fields. Grade 2 out of 6 mid-systolic ejection murmur is heard along the upper right cellular border. CD4 T lymphocyte is 280, and X-ray of the chest shows a hazy infiltrate in the right lower lung field. Which of the following is the most likely cause of this patient's symptoms? A, bronchoalveolar carcinoma, B, pneumocystis pneumonia, C, aspiration pneumonia, bronchiectasis, TB, mitral valve regurgitation, pharyngeal esophageal diverticulum. What do you guys think? Cool. Okay, I hope you guys are saying C because you think it's C, not because you guys saw it by mistake. I'm sorry about that. Good job. Okay, it's C. Definitely not leaked. Now, the most important thing in this question. So let's just say you did not foresee the answer. Okay. He's drunk currently. Homeless, meaning, for example, he is in a worse state generally, immunocompromised, and you hear crackles. Everything else in this question is kind of a distractor or something just to add on, because obviously when people tell you they're like full history, you're going to have a lot of details, right? But you need to be able to focus in on, okay, what is standing out in terms of what he's feeling right now? So he's presenting with crackles and dullness to percussion. That is not normal. Wheezing can be for any reason, but everything else that's being mentioned in this question doesn't really have much to do with his wheezing. It has more to do with the fact that he has crackles and dullness to percussion. He's coughing up sputum. Malodorous phlegm. Malodorous phlegm is not normal. That means you have something that's coming out of your lungs that's not supposed to be there, typically meaning that you have an infection because of something. And in this case, because he's intoxicated, the most likely cause is aspiration pneumonia, because he aspirated gastric contents, maybe because he was drunk and he lost, for example, like you don't have full control over your reflexes, such as your gag reflex. You can throw up and then, you can't close your throat properly, which is automatic if you were not intoxicated, okay? Yes, and then if this question asks you, what is the most likely organism that is causing this person's symptoms, what would the answer be? Good. Klebsiella pneumonia is the most likely in aspiration pneumonia, okay? Walid, strep pneumo, technically you're correct if for general pneumonia. Community acquired pneumonia is almost always strep pneumo, but for this specific case, it would be Klebsiella, okay? Yeah. Okay, next question. This is just like a little explanation. Cough, malodorous phlegm, alcohol use disorder, and reflux, hazy infiltrate. Oh yeah, history of severe heartburn. That was important too. Okay. Now, do you guys just want me to read the questions, or do you guys want to read the questions like out loud yourself? I'm going to read the questions because no one's answering. Okay. So, otherwise unremarkable. She smoked for 36 years. Temperature is 39. What is a normal temperature? Normal range. What do you want it under? Good. You want it under 37. Okay. Above 35, between 35 to 37. Okay. Blood pressure respirations are 20, normal. Blood pressure 132/84, normal. Pulse oximetry, oxygen saturation of 89, low. Auscultation, end expiratory wheezes, and decreased breath sounds and crackles are heard at the left lung base. Okay, I want you guys to know something here. When you have a finding that is on one side, and it's something like crackles, decreased breath sounds, dullness, that is a very good indicator it is pneumonia, right? And that is because typically lobar pneumonia, again, it's happening in one lobe. It won't always happen bilaterally. It can, not always. In typical pneumonia, it's usually on one side or starts on one side, right? In atypical pneumonia, it's usually bilateral, or like in bronchitis and etc. Okay? Chest x-ray shows homogeneous area of increased opacification in the left lower lobe. So basically, what is another word for opacification in this case? Good, consolidation, perfect. So which of the following is the most appropriate next step in diagnosis? Good, CT, because it was not leaked. I'm sorry, guys. Good. Now, let's just say over here, good, Faris, I was gonna literally ask about this. So Faris mentioned X-ray, then CT. So first line investigation is X-ray. So if you see that option, let's just say they didn't do an X-ray in the question and they say, what is your next step? X-ray, okay? If you're done an X-ray and you see opacification, you're like, that's weird. I wanna check it out more. Always CT, X-ray, then CT, okay? Next question. Do you guys have any questions about this question? Anything you want to say? Okay. When we get to the questions where it's like general, where I don't tell you like, it's general, like it's a mix of questions, and we'll talk more about every single option. But over here, I think it's pretty clear and straightforward. Most appropriate next step in diagnosis over here is CT, because this is typical pneumonia, or it's giving the picture of typical pneumonia. If it was giving the picture of atypical pneumonia, for example, person has bilateral reticulonodular infiltrates on imaging. They have a non-productive cough, it's dry, and they're in the military. I don't know, for example. Now, sure, you do an X-ray, sure, you'll do a CT, but what is something else that could maybe tell you more about that patient's diagnosis? Good job. Shema said it in the chat, cold agglutinins and urine test. Sure, a blood sample could help you, but the answer I was looking for was cold agglutinin test, because more, and urine test, because you want to find out the cause of the atypical pneumonia, okay? Culture typically, yes, Walid, is no good, because blood culture, you can sometimes get an answer, but otherwise culture, for example, sputum culture will not always help you, because you can't really gram stain those organisms very well, and you can culture them though under specific agars. We'll get to it later, okay? CT scan of the chest. Okay. I didn't reveal the answer to this one yet, so I'm happy so far. Okay, next question. A 61-year-old woman comes to the physician because of a 6-day history of cough, shortness of breath, and fever. She has also reported 4 episodes of watery diarrhea per day for the last 3 days. What is ringing in your head so far, just from this alone? Sure. Okay, nothing is fine also. She has chronic bronchitis, has smoked 1 pack of cigarettes daily for 30 years. Temperature is 39, cool. She has a fever, she has an infection, good. Pulse is 65. That can be normal for this patient, doesn't matter. Examination showed diffused crackles over the left lower lung field. Now, hemoglobin is 13, leukocyte 16. What is the normal leukocyte range? 4 to 11, okay? So 4,000 to 11,000 is typically your normal range. Platelet count is 150. That is also normal. 150 to 400,000 is your normal platelet count. Those things, again, these are distractors. They don't matter, right? But now let's go into serum. Sodium, 131. Do you guys know what the lower end of the normal range is for sodium, serum sodium? It's 135, okay? So I think it's 135 to 145 if I'm not wrong. Chloride is 102, that's within the normal range. Potassium is 4.7, also within the normal range, 3.5 to 5, okay? An X-ray shows consolidation of the lower lobe. Gram stain shows numerous neutrophils, but no organisms. Which of the following is the most appropriate pharmacotherapy? Let's go to the next slide. What is your guys' answer based off of this? So A, zanamivir, rifampin, amoxicillin, vancomycin, levofloxacin, itraconazole, cotrimoxazole. Damn pharma indeed. Okay, anyone else want to answer? Do you guys have a different idea of what the answer might be? Okay, good. The answer is E. Okay, good job. Now, before I go into the explanation, let's go back to this slide. What are the significant findings here that led you to your answer? You guys can answer out loud, by the way, if you want to unmute your mic. Okay, Ibrahim said diarrhea, hyponatremia, and no organisms. Ghazi said decreased sodium. Shema said intracellular. Very, very good. Very good. Walid's curb score 0. Good. Not significant in this case because they're just asking about the treatment. But if they're asking about, now, how do you want to give the treatment? Inpatient, outpatient, blah, blah, blah. That's when the curb score will come in handy. Okay? But good. Good you mentioned that. So again, perfect. Guys, decreased sodium, intracellular, diarrhea. Okay? And no organisms. So this is obviously telling you it might be Legionella. Okay? And how do you treat Legionella? What class of antibiotics? Macrolides, sure, and fluoroquinolones. Good. Okay. So there is no macrolide option here, but if you did have a macrolide option, you could go for that. In your exam, if they give you a macrolide option and a fluoroquinolone option, appeal that question for them to accept both. Okay. So this is the sketchy picture. I don't know who here uses sketchy, but this right over here, the flower, that's your fluoroquinolone symbol. Yeah, fluoroquinolone symbol. Here, over here in this corner, top left, macrolides, okay? And over here, you'll see, for example, like you usually find things on both sides, or you can find it at the base. You can use cysteine agar, charcoal agar, and that can be a question as well. So for example, same exact scenario, how would you wanna, which agar would you wanna use to culture this person's like causative organism? You could say charcoal yeast agar or cysteine agar. Okay, good job. You guys have like a few options. I know, was it Dr. Mohabbat who taught you this lecture? Yes? Okay, yeah, same for us. So her questions are usually very straightforward with this, but do pay attention, do watch the sketchy videos because you do want to know the agars, you want to know how to get to your diagnosis. Besides the imaging, I mean like the microbiology lab diagnosis and understand the treatment. Those are the two main things, okay? Now, next question. A 30-year-old woman comes to the emergency department because of a 2-day history of weakness. That's very vague. She also noticed that her urine is darker than usual. When does your urine become dark? It's okay if you guys don't know, you typically learn this in renal. Sure, concentrated renal issues. There's another answer I'm looking for. It might become more apparent by the end of the question, but I want to see if you guys are like thinking about it yet. It seems not, but it's okay. So we'll get back to it. For the past week, yeah, Faris medications can be a cause. For the past week, she's had persistent, non-productive cough and low-grade fever. She has seasonal allergies. She does not smoke, drinks 1 to 2 glasses of wine on social occasions. Her temperature is 37.9, so it's not significantly high, but it is high. So she has a fever. Pulse is 88, normal. Respirations are 18, normal. Blood pressure is 110/76, considered normal. When do you want to start worrying about the blood pressure? Like which systolic and diastolic? What numbers? Sure. Okay, good job, guys. Below 90 systolic and typically below 7, if I'm not wrong, 70 or 60 systolic. Okay, but more important, systolic. Yeah, thank you, Faris. Less than 90 systolic, less than 60 diastolic. Okay. She has conjunctival pallor, scleral icterus. Cardiopulmonary exam shows bibasilar crackles. Remainder of the physical exam shows no abnormalities. Lab studies show the following. Hemoglobin 7.1, low. Hematocrit 21, I forgot, I think it might be low. Mean corpuscular volume, 94, normal. Leukocyte count, 8,000, normal. Platelet count, 210, normal. Serum AST, ALT, pretty normal. Bilirubin, 4.3, direct 1.1, slightly high. Lactate dehydrogenase, very high. 1,251. That's very high. Haptoglobin, 5.8. Now, I want you guys to remember from heme first year. What is the significance of lactate dehydrogenase? If it's high, what does that mean? There's one thing you have to think about. Okay. Specifically, injury. Okay. Fair enough. More importantly, red blood cell breakdown. Okay. Yes, Momo, hemolytic anemia. Good. It's not very specific, but it is sensitive. Okay. Haptoglobin, significance, if it's low. What is it? What does haptoglobin do? Okay, so haptoglobin binds free iron, right? You're only gonna have free iron if your red blood cells are releasing the free iron. Otherwise, the iron is inside your hemoglobin, inside your red cells, okay? So this means there is blood cell breakdown. An X-ray of the chest shows bilateral patchy infiltrates. A peripheral blood smear shows spherocytes. Which of the following is most likely to confirm the diagnosis? A, Ristocetin cofactor assay. B, osmotic fragility test. C, direct Coombs test. D, Adams T13 activity, blah, blah, blah. E, hemoglobin electrophoresis. F, flow cytometry. G, pyruvate kinase enzyme activity. By the way, it's okay if you find this difficult. The questions are going in order of difficulty for pneumonia right now. Like I put them in that order, so it's okay. What do you guys think is the answer? It's okay if you get it wrong. This is why we're here. None of the above. Okay. Muhammad Shath, Momo, Ghazi, good job. Direct Coombs test. Now, can anyone answer and tell me what is the direct Coombs test? This is a little difficult. They're not going to test you on this specific concept in CVP, but you will be tested on it in 3 weeks' time. So regardless, it's very important. 3 weeks' time meaning hem-onc. Okay. Good, Faris. Good job. So it has something to do with hemolytic anemia. That's all I want you guys to know for now. It has to do with RBC breakdown, destruction, hemolytic anemia, exactly, antibodies, okay? So that's all you need to know. Direct Coombs test means there's antibodies basically forming against your red blood cells, and it's causing them basically to break down. That is literally it, okay? And that's just, it's a specific test, and it's gonna be positive. What is this person's etiology? What's causing their pneumonia? Very good. Mycoplasma. Remember in mycoplasma pneumonia, I'm going to quickly show you guys the sketchy. Can you guys still see my screen? Okay. Let me see if I can find it here. There you go. Perfect. Okay. I will put this in the presentation later before I send it to you guys, but I just want you guys to quickly see it over here. Please let me zoom in peacefully. Thank you. Okay. Can you guys see the picture over here? If you guys saw this picture, this was your clue. Okay. Cold agglutinin, they basically bind together. These are IgM antibodies, basically hold on to your red blood cells, and then it causes them to break down. Okay? That is what I want you guys to know about that. So, keyword, RBC hemolysis, if you see high LDH, if you see low haptoglobin, low hemoglobin, dark urine because hematuria. So this person is basically breaking their RBCs and it's going into their urine, okay? I want you guys to immediately think this person is having hemolytic anemia. Which pneumonia causes that? We learned about it, mycoplasma, atypical pneumonia. What is the treatment? That might be the question. What is the treatment? General class of antibiotics. Which one? Do you guys remember? Very good. Macrolides. Not doxycycline, macrolides. Doxycycline's a bit, it's more for doxycycline, more for chlamydia caused pneumonia and anthrax. Okay? God bless Sketchy. Okay. Getting a little bit harder because these types of questions, I know, guys, I know, they're really annoying because it's like it could literally be any of the above, but we'll get to it, okay? So let's get into it. Do you guys have any questions about the previous question? Sorry, before we move on. I don't want you guys to be confused about anything, and if you are, it's okay. You can let me know, and we can talk about it later, even if you want. Okay, I'm gonna take that as a no. Okay, so we're gonna move to the next question. Okay, so 12 hours after admission to the hospital because of high-grade fever for 3 days. High-grade fever for 3 days. A 15-year-old boy has shortness of breath. During this period, he had generalized malaise, meaning tiredness, and a cough productive of moderate amounts of green sputum. For the past 10 days, he has had a fever, sore throat, muscle aches, and these symptoms initially improved but worsened again over the past 5 days. His temperature is 38.7 degrees Celsius, pulse is 109, respirations are 27, blood pressure 100/70. He's 15, this is normal, this is fine. Pulse oximetry on room air shows an oxygen saturation of 93%. So it's low, but it's not like you're not worried about him dying right now. Decreased breath sounds and crackles heard over the right upper lung field. His hemoglobin concentration is 13.3, normal. Leukocyte count is 15,000. Is that normal or elevated? Elevated, good, okay. Platelet count is 289, normal. X-ray of the chest shows right upper lobe infiltrate. Which of the following is the most likely cause? What do you guys think? Okay, so Shema said Haemophilus influenza. I've had a few people say B. Okay, let's see. So the answer is B, okay? So this is very, 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 like the most typical case of pneumonia you will see. And anytime you see this, your first thing is gonna be, okay, it's most likely strep pneumo, community-acquired pneumonia. Almost always strep pneumo, okay? Haemophilus influenza could be a possibility, but remember, and you guys learned this in HNS. I'm sorry, I know you guys don't like it when people are like, oh, you learned this in POD, you learned this in Neuro, HNS, blah, 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 but I used to hate it too, and now I realize I'm that person whenever I'm telling people things. But in HNS, 3 most common upper respiratory tract infection organisms, strep pneumo, Moraxella, Haemophilus influenza, right? So this person, typically, even typical pneumonia, will usually start with URTI symptoms, so upper respiratory tract infection symptoms, and then usually they'll get better, and then they'll get worse all of a sudden because the infection has descended, okay? Most typically, it's strep pneumo. Haemophilus influenza will have other things, and you can always consider it, but for the sake of your guys' exams, focus on the high yield, okay? If you answer Haemophilus influenza and in your lecture she focused on that, again, you can appeal that question, okay? But you will have other things for Haemophilus influenza. Sometimes, like Walid said, you're gonna notice otitis media, epiglottitis. It's more likely to be in a younger child rather than in like a 15-year-old boy. It's more likely to be in like a 7-year-old or a 5-year-old, and everything, okay? So strep pneumo, and what are you gonna treat it with? Guys, yalla, it's okay if you get it wrong. Penicillin, beta-lactam, augmentin. Good, yeah. So you can start with augmentin and macrolides, fluoroquinolones. Especially in kids, macrolides and fluoroquinolones, levofloxacin is a very commonly used drug, okay? So all of these are correct, but the most, like, first line, most common one, you can usually start with augmentin, okay? And by the way, you guys will see a lot of pneumonia cases when you come to the hospital, okay? So it is an important thing to know, so please do review it, okay? I know there's a lot of pneumonia questions, guys, but I've noticed every single year, it's not just you guys, and a lot of people did ask me, but It is typically the most confusing thing because just like, okay, what's the treatment? And especially when you get into CURB 65, how are you going to treat this patient? For how long? Blah, blah, blah. And it's very, very important, not just for CVP, but for your next 2 years in the hospital, for internship, for residency. You're always going to have to know about pneumonia, okay? So next question. Do you guys have any questions about that? Or do you want to move on? Clear, okay. A 72-year-old woman brought to the emergency room with fever, myalgia, cough for 3 days. She lives in an assisted living facility and several of her neighbors have had similar symptoms. She has hypertension treated with lisinopril, an ACE inhibitor. She has not been vaccinated against influenza. Temperature is 38.9, pulse is 105, respirations are 22, blood pressure is 112/62. Pulse oximetry on room air shows an oxygen saturation of 89. Leukocyte count is 10,500, so it's normal. Serum creatinine is 0.9. Serum procalcitonin level is 0.05. An X-ray of the chest shows reticulonodular opacities in the lower lobes bilaterally. Blood sputum cultures are negative. The patient is admitted to the hospital and empirical treatment with ceftriaxone and azithromycin is begun. 2 days after admission, her temperature is 37.6 degrees Celsius. Pulse oximetry, 96 on room air. Her serum procalcitonin is 0.04. Which of the following is the most appropriate next step in management? So let's first answer the question and then we're going to get into it, okay? So you guys are saying A, continue ceftriaxone and azithromycin to complete 7-day course. Does anybody else have any other answer? E, repeat sputum culture, okay. Anything else? Do you guys have any other idea? A. All right. No. The answer is discontinue ceftriaxone and azithromycin. So it's okay, guys. I answered A the first time I was practicing this question too for preparation for the session. Because typically you don't want to stop antibiotics in the middle of the course because that's dangerous, right? Like resistance and whatnot. But over here, what we have to recognize is what type of, why did they stop her antibiotics? What's the reason? Like, what's the reasoning behind that? Because they're not going to randomly do that if she's having an infection active. She improved, sure, okay, but that's not the reason, because even if you're improving, you always want to finish your antibiotic course. So there's a reason that they stopped her antibiotics. It means she didn't need it, right? Meaning that her infection was not bacterial. Good. Her infection was not bacterial. Now, it's okay. This is a little challenging. So let's break down the question and see, okay, how can I tell it's not bacterial as opposed to viral? Hint number one, maybe, is she has not been vaccinated against influenza. I missed that too, okay? But that's not an obvious thing, okay? So like, sure, she wasn't vaccinated, but the most common cause of pneumonia is typically like strep pneumo, from what you guys learned, right? Otherwise, typically, honestly, it's viral. Most of the time it's viral. Like, you guys are all getting sick right now. We're all getting influenza if we're not getting COVID, okay? So that's basically what's going around. And you see how you cough and you see the type of like phlegm that you have, it's not colored. Now, I wanna go into, her leukocyte count was not like significantly high. When your leukocyte count goes higher, sure, obviously it goes higher in viral infections, but not as much as it will in bacterial infections because you don't require as many neutrophils to literally kill the bacteria directly. That's why it's not going as high. So that's like another hint, okay? Now, this question, by the way, is really hard, okay? And this is either a step 2 question or a medicine shelf question. And the reason I put it in here is because sometimes they might pause recording, screw you over in the exam, unpause recording. But okay, so procalcitonin is a really important marker of sepsis, meaning there's bacteria in the blood, right? So it doesn't have to be severe sepsis. It'll just tell you, hey, a bacterial infection is going on. It's also in the blood, okay? So if the procalcitonin is high, that will give you a hint this is bacterial because you're not going to get viral sepsis. I have not seen a case of viral sepsis, barely ever talk about it. No, okay? Usually sepsis is, it's bacterial, okay? So procalcitonin is low, that's another hint, okay? Blood and sputum cultures are negative. That's your other hint. Empirical treatment will start all the time. You will always start because while you're doing the culture, you want to make sure like you're covering everything possible and you're not worsening their infection. So after admission, she improved, usually with viral pneumonia. Unless the patient is immunocompromised, it's symptomatic treatment, okay, and just supportive. And she improved. And her serum procalcitonin did not really change, and it was still below normal, okay? Like it was low. So not below normal, sorry. It was still in the normal range. So that tells you this is viral. She does not need to continue her antibiotics. No, you're not going to cause resistance if you stop your antibiotics mid-course if you confirm it's a viral infection, because right now, if you're giving her antibiotics, you're killing her healthy microbiota in her like respiratory tract, in her gut. So you want to stop it immediately. There's no reason to continue it. If they confirm it's bacterial, either you continue the full course and that's it, or you change the antibiotic, okay? Do you guys have any questions about that? When you see a question like this, go for the logical answer. It's okay if my logical answer first was also A, okay? But when you realize it's viral, you want to just stop immediately, okay? But do you guys understand the hints in the question? Momo, yes. So they start, so okay, like even in the hospital here, if a patient has pneumonia symptoms, you will, and even if it's like reticulonodular, you can see reticulonodular in atypical pneumonia caused by bacteria, right? But you're confirming through lab diagnosis and testing that it's viral. In the meantime, you want to make sure that you're giving them antibiotics in case. And another reason that you start the patient on antibiotics is because usually viral infections turn bacterial because your immune system is down, so the bacteria can invade and start replicating faster and everything. So yes, you do start with antibiotics, but once you confirm it's viral, you stop the antibiotics. If you confirm it's bacterial, you continue the course, okay? All right, so this is a new question, but is this clear? Do you guys want to discuss anything specific? The reason the answer is not B, by the way, like, oh, it's viral, why don't you give her antivirals? She's not immunocompromised and she improved. If she's worsening, and let's just say she's like, she's becoming hypotensive, her oxygen saturation is not increasing, then you would say start treatment with oseltamivir. Okay, that would be your answer, or start antiviral treatment, okay? Now, guys, by the way, good job. That was a 4-hammer question, okay? So don't beat yourself up. I got it wrong too, and I finished IM, okay? So I had no excuse. You guys have an excuse. Okay. Now, next question. A 67-year-old woman is brought to the emergency department for evaluation of fever, chest pain, cough productive of a moderate amount of greenish yellow sputum for 2 days. Are you guys getting the hang of how they're going to start asking about pneumonia? Like, do you guys understand basically the starting line of like, okay, for sure this girl has pneumonia and I'm not going to question further. Is it clear? Yeah, okay, thanks. Cough productive of a moderate amount of greenish yellow sputum for 2 days. During this period, she has had severe malaise, chills, difficulty breathing. She has hypertension, hypercholesterolemia, type 2 diabetes, blah, blah, blah. Okay, we get it. She has she smoked 1 pack of cigarettes daily for 20 years, but quit 5 years ago. Current medications include simvastatin, captopril, metformin. So a statin, ACE inhibitor, and anti-diabetic drug, okay? Temperature is 39 degrees, high. Pulse is 110, high. Respirations are 33, high. Blood pressure is 143/88. Pulse oximetry on room air, 94%. Crackles are heard in auscultation over the right upper lung field. Lab leukocytes, 12,300, that's high. Erythrocyte sedimentation rate of 60, high. Urea nitrogen of 15. In all honesty, I completely forgot if that's high or not. I don't think so. A chest x-ray is shown. Which of the following is the most appropriate next step in management? So let's look at the chest x-ray. This is the chest x-ray. So what are you guys seeing over here? Tell me like literally you're finding as if you're telling the doctor, like, okay, in the what side, which lobe? Good, Shema. So right upper lobe consolidation. Very good. Perfect. And you can even see it in the lateral view. okay? Right upper lobe consolidation. So this patient has typical pneumonia, okay? Most likely, you do a sputum culture, obviously. Now, quick question. What color will the sputum be? What is the difference between the sputum of someone who has bacterial pneumonia versus viral pneumonia? Faris, the difference of the sputum color between someone who has bacterial pneumonia versus viral pneumonia. Good. So viral will be clear, white, scanty. Good. Bacterial is yellow, severe, green. Okay. And do you guys remember why? Did they teach it to you this time in mole? But they taught it in mole in first year, I remember. Walid, kind of, yeah, sure. Plus, thank you. Yeah, breakdown of neutrophils. So basically, if you guys remember, you have an enzyme called myeloperoxidase, okay? And when it's breaking down heme to aid in like basically making free radicals for to break down bacteria cell wall, that's basically what makes your sputum green, the presence of heme, okay? Is that clear? You guys don't really need to know that, but it's just like a fun fact to know. That is why if you see green sputum, always think this is bacterial. There's no way this is viral, okay? If you see light yellow, clear, viral. And then if it keeps getting worse, then you can start to suspect bacterial, okay? So this is her x-ray. And now, what is her treatment plan? Guys, I'm sorry, I don't make the choices, okay? But let's go back. So which is the most appropriate next step in management? So now in this question, in the choices, you're seeing inpatient, outpatient, ICU. So what do you want to think about? Walid mentioned it in the chat earlier. Good, the curb score. Okay, now for this patient, let's quickly go back. What is her curb score? 2. Okay, Walid said 2. Walid, tell me why you said 2. What are the 2 things that made you think about it? Age and respiratory rate. Good, okay. BUN is high. I'm not sure. I think it's supposed to be above 20, Shema, but we'll check. I have the curb score coming up. Okay, but sure, good. It's 2. Okay. Now, what is your treatment plan? Okay, BUN needs to be above 30. Okay. Sure. Or respiratory needs to be above 30. I think the BUN was 20. We'll check in a second. Good. So 2 inpatient combo therapy. So which answer is that? Very good. Guys, excellent. Okay, you guys are saying E. So, guys, mashallah, this is a 5-hammer question, so it is hard. Okay, so good job. Inpatient treatment with azithromycin and cefotaxime. So you'll usually give them a cephalosporin, usually cefotaxime, sometimes cefepime, it depends. You guys don't need to know that much, but cefotaxime and azithromycin, okay? So good job, you guys, really, really good. And now look at the curb score over here. So yeah, BUN 20 plus. So confusion, BUN has to be above 20, respiratory above 30, blood pressure, like we said earlier, 90 over 60 or below, age above 65. 0 to 1, outpatient, you give them their antibiotics, they take them orally at home, okay? Score of 2, inpatient, so Walid, good job. And ICU is 3 and above, okay? So that's how you know over here, when you guys see someone, if it's a pneumonia question and you see that, second thing you should be looking at, or if it's not the first thing that you looked at, should be the age. Okay, this person has pneumonia. How old are they? Okay, they're above 65. Okay, now let me pay attention to like the curb criteria. Let me look out for the respiratory rate, their BUN if it's mentioned. Are they confused? Over here, this patient does not seem confused, if I'm not wrong. But you're right, the respiratory rate was 33. So that was a very important thing. BUN over here was 15. So that was not part of it. If it was above 20, then you would consider ICU admission. Okay. Good job, guys. So don't be alarmed when you see so many options because you guys got that. Okay. So don't even worry about it. E. Is that clear? Yes. All right. Okay. That's your curb criteria. Remember this, it's very important. It's very important for your exam and it's very important for the rest of your life as a physician, okay? We don't use the PSI criteria, right? Walid, to be completely honest with you, I don't even know what the PSI criteria is. I completely forgot. I'm so sorry. So I have no idea. I can check for you though, later, okay? Pneumonia Severity Index. Oh, yeah, I'm sorry, that still didn't help me. I completely forgot about it. I have no idea. But if they want you to use that in your questions, listen, in your exam, if they bring up a thing and they want you to use the they're not gonna expect you to use the long line criteria. If they do in this exam, that's really unfair. We don't have to use that in real life right now. So curb 65 is it, okay? That long line criteria, you should know it for the sake of understanding like when pneumonia is severe or not, but you do not have to memorize anything from that, okay? If they ask you about it, they're just gonna ask you specific questions. They're not gonna ask you to fully apply it or anything like that in your exam. From what I remember in my exam in CVP third year, they did not, I don't even remember getting a question about the PSI. It was literally only curb 65. Literally, that's it, okay? So I think stick to this, and then for that, just read it and understand it, but you don't have to memorize it. Is that clear? I'm gonna assume that's clear. Okay, awesome. I think this is the last pneumonia question. Guys, I didn't ask a lot of questions in the other sections. I just focused in on pneumonia. This should be the last one. And then we're going to do like 2 or 3 specific ones and we're going to go into general, okay? But this one is about viruses. So fun stuff. A 72-year-old man comes to the physician with chills, nausea, diffuse muscle aches for 3 days. His niece had similar symptoms 2 weeks ago, and H3N2 influenza strain was isolated from her respiratory secretions. He received his influenza vaccination 2 months ago. His temperature is 38. Rapid flu test is positive. Which of the following mechanisms best explains this patient's infection despite vaccination? What's your guys' answer? A. Good job. Oh, wait. Good job. Yeah. Okay. The answer is A. Can anybody tell me what that is? Good. Influenza type B, antigenic drift is the answer I was looking for. So a minor mutation. Yes, good job. So this is one concept. The reason I just asked you guys about this under this is because you guys have to remember this is a really important concept, okay? For step 1 for your exam. So sorry guys, I'm getting over the flu. So remember this, generally, antigenic shift is scary, antigenic drift is cute, okay? Over here you can see, so antigenic shift is an example of like us getting COVID, like the pandemic. Antigenic drift is the reason we're all getting sick right now, okay? So do you guys want me to go into detail about this, or are you guys okay with it? It's clear, I think. Okay, all right, let's move on then. Restrictive lung diseases. We're done with pneumonia. We're done. Is there anything specific? Let me just, okay, I'll quickly say a few like key points about pneumonia for you guys to keep in mind, and I'll write them down in this slideshow before I share it with you guys after we're done, okay? Green yellow sputum, nice Eman. Green yellow sputum, bacterial. Scanty white, light yellow, viral. Empirical antibiotics, cephalosporin plus fluoroquinolone, usually cefotaxime, levofloxacin, okay? Lobar pneumonia is usually when it's typical. Atypical will not always be lobar pneumonia. It will usually be reticulonodular, or it can be on bilateral, or it can be unilateral. Typical is usually unilateral, okay? Always pay attention to the age because you want to see if you can apply the curb 65 criteria to that patient. And the last thing is Legionella hyponatremia, urine antigen test, cysteine agar, charcoal yeast agar. Mycoplasma pneumonia, they're gonna maybe have dark urine because they're gonna have blood breakdown, okay? You treat it with macrolide. Both with macrolides, Legionella, also fluoroquinolone if you have that, okay? Strep pneumo is the most common cause of typical pneumonia. Haemophilus influenza, more common in like smaller children, but it's also a very common cause. And what else? I wanted to say something, I forgot. Klebsiella, aspiration pneumonia. That's what I wanted to say. So Klebsiella is also Nosocomial. So if someone is like hospitalized for a long time, you might also want to consider Klebsiella, okay? More also for UTI. You're gonna learn that in your later blocks, but fun fact. Yeah. Okay, so restrictive lung diseases, let's move on. All right, okay. So a 29-year-old African-American woman comes to the physician because of a 4-month history of fever, progressive shortness of breath, and a dry cough. During this time, she's also had a 5 kg weight loss. 2 months ago, she was in Kenya for several weeks to visit her family. Physical exam shows fine crackles and wheezing over both lung fields. Her serum calcium concentration is 11.8. X-ray of the chest shows reticular opacities in both lungs and bilateral hilar lymphadenopathy. Which of the following is the most likely underlying mechanism of this condition? If you guys have studied, you guys don't need my help answering this question. There are so many keywords in this. B, perfect. Granulomatous inflammation. What does she have? What's the diagnosis? Or like your suspicion? Sarcoidosis. Okay, someone said TB. Not TB. I understand though why you would think TB. She traveled recently to Kenya, and that can be very telling that she might have TB, weight loss as well. However, over here, dry cough, and what's it called? I think that, oh yeah, sorry, dry cough and your high calcium, okay? And bilateral hilar lymphadenopathy, yes, that's very, very pathognomonic usually of like sarcoidosis. However, in certain TB cases, you can see that. Usually it's gonna be unilateral, it's gonna be on one side. That's typical, okay? And like more than 90% of your cases. However, over here, I understand why you would think TB, and that's also kind of granulomatous inflammation technically. Now, what is the difference between granulomas in TB versus sarcoidosis? Very good. Non-caseating in sarcoidosis, caseating in TB, okay? So does anybody know why the calcium concentration is high in sarcoidosis? It's more of like a biochemical question, but they do test it in step 1, and you probably got a practice question on it if you did UWorld or AMBOSS questions up until now. If you guys don't know, it's okay, I can explain. You can just say, I don't know, IDK. Okay. So the reason is their alpha hydroxylase activity is high. Yes, vitamin D. Good job, Shaf. Vitamin D. So basically, in granuloma formation, was it neutrophils or was it? Ya Allah, I'm sorry. One of the leukocytes, I think it was neutrophils if I'm not wrong, or it was the other one. They have high alpha hydroxylase activity when there's granuloma formation. Alpha hydroxylase is involved in vitamin D and basically calcium homeostasis. That's all you need to know. I'm sorry I forgot the exact cell, but I think it's neutrophils if I'm not wrong, okay? But that's it. That's why you have high calcium, okay? And that's why you can also see high calcium in TB, okay? However, over here, there's a few things I want you to remember, keywords for sarcoidosis, so you don't confuse it, or if you see it, you can be like, okay, typical sarcoidosis, but it doesn't matter. Even if it's TB, the answer, by the way, would have been the same, okay? It would have been the same. Granulomatous inflammation. Technically necrotizing inflammation, but the reason that they put both here is because they want you to choose one. Granulomatous inflammation is more correct, okay? Because it's sarcoidosis. Even if it was TB, the thing is this applies to both, okay? So sarcoidosis, African-American. Sorry, I don't know what this point is. I think I forgot to edit this, but African-American, it's more common in African-Americans, high calcium, granuloma formation, non-caseating, bilateral hilar lymphadenopathy markings on x-ray. If you guys hear this, don't think further than sarcoidosis, okay? Do you want to move on? That's all I had for restrictive, guys. I'm gonna keep the rest in the other, yeah. Okay, obstructive, I think I only have one as well. 65-year-old man comes to the physician because of a 10-month history of progressive shortness of breath, cough productive of small amount of white phlegm, bilateral and expiratory wheezing is heard on auscultation of the chest. Pulmonary function tests show total lung capacity of 108% of the predicted, FEV1 that is 56% of the predicted, and an FEV1 to FVC ratio of 62. Which of the following interventions is most likely to slow the decline in FEV1 of this patient? Let's answer and then let's talk about the question. Okay, Ghazi said E. Ibrahim said A. What do you guys think? I want at least 2 more people to answer. Okay, C, salmeterol therapy. All right, okay. So the answer is A, smoking cessation. The key word here to get to this answer was slow the decline. Slow the decline. So these don't slow the decline. They just improve your symptoms, okay? This smoking cessation will actually slow the decline. It'll allow you to stop basically inflaming your lung tissue and your bronchi. So this is why it'll slow the decline. This is a 1-hammer Q. Is it? I think I wrote it down. I didn't. I think it was a 1-hammer question, but it doesn't matter. I got it wrong the first time, honestly, when I was answering it like a few hours ago. Because I thought it said show the decline instead of slow the decline. But slow the decline, guys, if you see slow the decline, if you want to reverse the progression of any obstructive disease, if you see smoking cessation as an answer, you don't think about anything else. You go for smoking cessation. Now, fluticasone therapy, salmeterol therapy, these are long-term therapy for obstructive lung disease for symptomatic treatment. It's to open up their airways and to decrease inflammation overall. But it's not going to slow the decline of their disease if they continue to smoke. Breathing exercises is also symptomatic. Alpha-1 antitrypsin therapy is useful in emphysema. However, yes, emphysema is, what do you call it? Obstructive. However, it is, this question is missing details that would basically lead you to emphysema. Basically the diffusion capacity of carbon monoxide. Okay, that's an important thing that you want to know before you answer final emphysema. Okay, is this bronchiectasis? Maybe, maybe not. We don't know. However, bronchiectasis is obstructive, so it could be bronchiectasis. However, bronchiectasis is more common, for example, if you see like a patient who has a known case of cystic fibrosis, if they have recurrent lung infections, if they have lung malignancy and they keep getting pneumonia and whatnot, okay? No smoking history in the vignette. That's also, yeah, another thing. So emphysema is more common in smokers. So there's no smoking history over here. This patient most likely just has asthma, like long-term asthma. 108% of the predicted. If you see, okay guys, why is the lung capacity increased in obstructive lung disease? Very, very simple reason. Trapping. They basically cannot breathe it out well enough because their airway is like this, okay? FEV1, what does that stand for? Pulmonary function tests are very important, so I want you guys to understand this really well, the FEV1 to FVC ratio. Tell me what FEV1 is and what FVC is. Forced expiratory volume in 1 second, good. So how much you go basically, that's literally it, okay? Theirs will be decreased because, again, trapping, like Shema said, their forced vital capacity is increased because they can actually breathe out a lot if you give them enough time to. They just need more time to breathe it out because it's trapped inside. So that's why their ratio will be low, okay? Lung capacity is 108% of the predicted, meaning there's just more air trapped in there. So their AP diameter will be increased. Wider, good. It'll be increased on X-ray. Okay, good. Is that clear? I think this is the only obstructive disease I have. Because I just want you guys to get the hang of like, okay, this is basically what they're gonna have in here. This is very obviously obstructive. And then for restrictive, this is like a clear case of like restrictive. It's an example of a restrictive. I'm gonna go into more of like the pulmonary function test relating to restrictive later. Okay, there's a few questions. Is this clear? Clear, awesome, perfect, okay. Other topics, AKA tumors. Okay, there's 2 or 3 of these questions and then I'm gonna give you guys a break, like 5-10 minutes. And then we have just a few questions of like, they're not specified in any category because I want you guys to practice the differential. Does that sound good? Like the break time and whatnot? I'm gonna assume yes. I'll ask you again in 5 minutes. Okay. 56-year-old man comes to the physician for a follow-up examination 1 week after chest x-ray shows solitary pulmonary nodule. He has no history of major medical illness. He has smoked 1 pack of cigarettes daily for the past 30 years. Physical examination shows no abnormalities. Tuberculin skin test is negative. A CT of the chest shows a 2.1 centimeter well-circumscribed calcified nodule in the periphery of the right lower lung field. CT guided biopsy, the lesion is performed. Guys, calm down. Okay, cool. You guys know the answer. But either way, on histo, disorganized hyaline cartilage interspersed with myxoid regions and clefts of ciliated epithelium. Diagnosis, like you all literally said, A, pulmonary hamartoma. Can anybody explain pulmonary hamartoma to me? What does that mean? Cool, it's a benign tumor. Good. What else? Disorganized normal tissue. Basically, tissue that's kind of like what are you doing here? It's basically that. If you ask that question, it's a hamartoma. Okay? That's clear, so I'm going to move on. You guys all knew that. Okay. 61-year-old man comes to the physician because of a 2-month history of a cough productive of clear mucoid sputum. He has smoked 1 pack of cigarettes daily for 33 years. Physical examination shows no abnormalities. Chest x-ray shows a 2 centimeter solid nodule in the periphery of the lower left lobe. Bronchial biopsy of the mass shows numerous mucin-filled epithelial cells lining the alveolar basement membrane. Cells have prominent nucleoli, coarse chromatin. Some cells have multiple nucleoli. What is most likely diagnosis? I'm sure you guys all have it down. Good. Adenocarcinoma in situ. Now, what would the key words be if, let's just say they had adenocarcinoma versus adenocarcinoma in situ? Good, Walid. Periphery, adenocarcinoma. Good job. Also, hamartoma, usually peripheral. Mucin, okay. Yes. Good job, Shema. So invasive means no longer in situ. So this one says over here, lining the alveolar basement membrane. If it's lining, it's not invading. And that's why you'll say in situ. So if you have both options, be mindful of that, okay? So mucin filled, multiple nuclei, basically it's going crazy, so it's cancer. And clear mucoid sputum. If you have a lot of clear mucoid sputum, that should give you a hint that a lot of mucin production. This is probably a mucin producing cell-based tumor, adenocarcinoma. Now, what would the keywords be if you wanted to answer small cell carcinoma? Centrally located, good smoker, yeah. That's basically it, yeah. Pulmonary scant cytoplasm, very good, yeah. You guys have probably seen this question before. I think I got it from your guys' practice questions. So pulmonary hamartoma, you guys just saw that. Sarcoidosis, you guys just saw that. Carcinoid tumor, that's an important one. What would you guys think about, or like what would you guys see in the question stem? Chromogranin staining, good. Serotonin, sure, yeah. People can maybe have even mood changes literally if it's like a neuroendocrine tumor, people can have literal mood changes. So if they ever have that, usually they're not going to put that in the question stem, but doctors might talk to you about that. That's like a keyword or phrase that you might hear, okay? Endobronchial tuberculosis, we know the TB, we know the TB keywords, okay. I wanted to show you guys something and I forgot to put it on here. Just give me 1 second. It was from step 1 from the first aid. Just give me 2 seconds. Okay. 2 seconds. Okay. I just wanted to share this with you guys really quickly. This is literally all you will ever need to know for your final. Here, share. Can you guys see this? Yes, all right, okay. So like you guys said, sorry. Adenocarcinoma, peripheral, squamous cell carcinoma, forgot to mention that. Central, and history of smoking. That's the first thing you want to think about in smokers. Squamous cell carcinoma is the most common cancer in smokers, okay? but you will see, what do you call it? You will see keratin pearls, okay? They look swirly. That's what you'll see. And you can literally see that over here in D. These are keratin pearls, okay? With intracellular bridges and desmosomes, okay? Paraneoplastic syndrome also accompanies SCC. Good job, Walid, yeah. You're going to have hypercalcemia because you have PTH-related peptide, okay? So it's gonna act like PTH and it's gonna cause calcium homeostasis to kind of go out of bounds and you're gonna have hypercalcemia, very good. In carcinoid tumors, you might have serotonin syndrome-like symptoms. So you guys will learn more about that in GIT. But basically, you'll see flushing, diarrhea, wheezing. So if there's someone, let's just say they're like, I don't know, you see these symptoms, and obviously it's a CVP exam, you're going to think about carcinoid tumor. In GIT, if you see this, you're going to think about possible carcinoid tumors, maybe of the lung, maybe of the GI tract, okay? But that's basically what I wanted to show you guys, how to differentiate. I'm gonna again keep the notes. I'm gonna put them back into the slideshow before I share that with you, okay? Before I send it to you guys. Now, before we move on, would you guys like to take a break before we move on to like non-specific questions, or do you want to move on? Okay, someone said no, continue. How about the rest of you? There's like 10 of you, so continue. Okay, awesome. Okay, sure. So we'll move on directly. Okay, so now these questions, I did not categorize them. So I want you guys, up until now, you should have a pretty good idea of how different general diseases will kind of manifest and present in the question stem. Okay, so over here, I'm not going to tell you what the question is about, obviously, but you're going to see it and we're going to come to a differential together. Okay, so a 70-year-old man with a history of hypertension and atrial fibrillation comes to the physician for shortness of breath with mild exertion, progressive weakness, dry cough, and has persisted for 6 months. He has smoked a pack of cigarettes daily for 45 years. His medications include warfarin, enalapril, and amiodarone. His pulse is 85 per minute and irregularly irregular. Physical examination shows enlarged fingertips, markedly curved nails. CT scan of the chest shows clustered air spaces and reticular opacities in the basal parts of the lung. Which of the following is the most likely underlying mechanism of this patient's dyspnea? This question is kind of niche, in my opinion. It's a little challenging. This is definitely step 1 vibes. There's one keyword you guys have to focus on, and that is it. And I will tell you what it is after more of you answer. Faris said D, bronchial hyperresponsiveness. Ghazi said G, excess collagen deposition in the extracellular matrix of the lung. Okay, does anyone else have any? Okay, B, increased pressure in the pulmonary arteries. I understand why all of you said what you said, to be fair. However, the answer is G, okay? Excess collagen deposition in the extracellular matrix of the lung. So Ghazi, good job. Now, over here, I need to remember one thing. Person with atrial fibrillation, usually they'll be given an antiarrhythmic. Over here, it's amiodarone, right? Amiodarone is known for causing pulmonary fibrosis. Okay, it can cause pulmonary fibrosis. Now, I don't expect you guys to come to that thing immediately when you read this question. I personally did not. Even up until now, I don't. However, when you read the full question, you go back and you're like, oh, okay, they're on amiodarone. I remember we learned about that. A side effect of amiodarone is pulmonary fibrosis, right? And this person has atrial fibrillation. So obviously that means they're continuously taking it. It's not just an acute treatment. That is more likely to cause pulmonary fibrosis. If you're in the hospital getting amiodarone in acute treatment, for example, like you're resuscitating a patient, they're in cardiac arrest, or they have like whatever the hell going on with them, they're not going to develop pulmonary fibrosis from like a few, IV like infusions of amiodarone. So this person has fibrosis going on, and fibrosis pathologically is excess collagen deposition in the extracellular matrix of the lung. Now, why isn't the other thing? Let's just quickly go through it. Malignant neoplasm, that's a reach for this question. Like, why would you say that? It's kind of like, why would you say that? Understandably, people might say that if they see, okay, enlarged fingertips, so clubbing, curved nails, clubbing, that can happen in malignancy. However, that can also happen in restrictive lung diseases. So there's no reason for you to say malignant neoplasm specifically. Now, increased pressure in the pulmonary arteries. I completely understand why you would say that first, because this person has an irregular beat, atrial fibrillation. However, atrial fibrillation typically is in the left atrium. The left atrium is pumping into the left ventricle. Left ventricle is not going to the lungs. It is going to the rest of the body. So typically you would see this person having a stroke, not pulmonary embolism. Does that make sense? Now, chronic airway inflammation. Understandably, smokes a pack of cigarettes a lot. However, reticular opacities in the basal parts of the lung. So you wouldn't go for chronic airway inflammation. That person will most likely have like sputum production, coughing 2 months out of the year or 3 months out of the year consecutively for 2 years, giving like chronic bronchitis, whatever. That's when you would say this. Bronchial hyperresponsiveness and obstruction, that's giving asthma. It's giving asthma. Okay. Fluid leak into the interstitium and alveoli, that would be in pulmonary congestion. However, this patient does not have signs of pulmonary congestion. Pleural scarring, that would happen in like patients who work in jobs with a lot of asbestos exposure. Okay, so that's something that we would want to look for, and that would be like mesothelioma causing. Okay, I'm trying to think if there's anything else for pleural scarring, but that was a main point for pleural scarring. So if you see, let's just say over here, okay, atrial fibrillation, and if it's like, if you're not sure, either this could be a CVP question, a cardiovascular question, or a pulmonary question. The reason I brought this is because it's challenging, because you're like, what is this? Is this a pulmonary cause or is this a cardiac cause? What is this? When you see something like this, besides the age here doesn't really matter in my opinion, because amiodarone can cause fibrosis at any age, okay? But the one thing you want to look at is, okay, they have atrial fibrillation. I have to pay attention to what kind of symptoms they're developing, what medications they're taking. Like I said, atrial fibrillation, typically left atrium, blood clot will form, go into left ventricle, will be pumped to the rest of the body. So they will either have a problem in one of their limbs, they will have a problem in maybe their coronary artery, so they'll be presenting with an MI. That's more rare. Most of the time, they're presenting with stroke symptoms. This patient does not have stroke symptoms whatsoever. Okay? The other thing is enlarged fingertips, markedly curved nails. Clubbing does not happen in obstructive diseases as much as it happens in restrictive diseases. People do not know the answer as to why. I tried to research it today. There's no specific reason. Hypoxia induced, you have more, sorry guys, vascular endothelial growth factor, you have more angiogenesis, blah, blah, blah. That's basically what's causing like the curvature of the nails and clubbing. That's basically what causes clubbing. Why does this happen in restrictive lung diseases and not really obstructive? Couldn't tell you. Not even your pulmonologist could tell you. He doesn't know. There's no specific clear-cut answer, but that's just the way it is. So that's another clue. The only time pretty much in obstruction where you'll see clubbing is like very, very advanced COPD, brink of death COPD, or malignancy, okay? So I did a lot of explaining for this question. Do you guys have any questions at all? It's okay if you do. Like, is everything clear? Do you guys, like, clear? All right, okay. Next question. So 54-year-old woman comes to the physician for worsening fatigue and dyspnea for several months. She has not seen a physician in 10 years. She's concerned about the appearance of her fingernails. Photo of her hands are shown. What is the most likely underlying cause of the patient's nail findings? This is a very vague question. Good job, guys. C, idiopathic pulmonary fibrosis. So like I just said, now when I was making this PowerPoint, I didn't think that this question, I didn't realize it would be right after that one. So, but the answer is pretty clear. Pulmonary fibrosis causes clubbing more often, way more often than obstructive pulmonary diseases do, okay? So if you see clubbing, first think of restrictive, then think of malignancy, then last, think of obstructive causes, okay? So idiopathic pulmonary fibrosis, it's a female, 54 years old. This is the most likely thing. Iron deficiency anemia causes what? What nil findings will that cause? I made my tea way too sweet. Koilanikia, good. Okay. PDA. You could technically see clubbing in PDA, but she's 54. She's not a child. So, yeah. Bronchial asthma, again, obstructive, you're not really going to see. Unrelated, pretty much unrelated, right? PDA is unrelated here. COPD, again, you're not going to see it much in obstructive. And also, guys, when you see something where it's like a question like this, it's pretty vague, and you see both asthma and you see both COPD, they're both obstructive, avoid that, okay? So that's like a skill when you're answering a question. If you see two answers and they're pretty much saying the same thing, it's not going to be either of them, okay? So just rule them out immediately and make your life easier, okay? Is that clear? All right, I'm going to move on. All right, 62-year-old man is brought to the emergency department with a 2-day history of cough productive of yellow sputum. What is this? Pneumonia. Okay. He has fever, chills, worsening shortness of breath. 10-year history of hypertension, hyperlipidemia. He does not drink alcohol or smoke cigarettes. His current medications include atorvastatin, amlodipine, metoprolol. His temperature is 38.9 degrees Celsius. Pulse is 105. Respirations are 27. Blood pressure is 110/70. He appears in mild distress. He has rales over the left lower lung field. Remainder of exam shows no abnormalities. Leukocyte count is 15,000, 87% segmented neutrophils. Now, before I move on, when you have a very high percentage of segmented neutrophils, what type of infection do you have, viral or bacterial? Very good, bacterial, immediately bacterial. High neutrophils, remember, neutrophils are the ones making myeloperoxidase. You want your neutrophils to be there to make myeloperoxidase because you have bacteria. If you have viral, usually you'll have more lymphocytes, okay? Because you're asking like your CD4 T helper cells, natural killer cells, they're the ones taking care of virally infected cells because they're your own body cells, okay? Bacterial cells are foreign. Your body doesn't make them, okay? So ABG analysis shows pH of 7.44, PO2 of 68, PCO2 of 28, HCO3 24, O2 saturation 91. X-ray of the chest shows consolidation in the left lower lobe. Asking the patient to lie down in the left lateral decubitus position. What would most likely result in which of the following? A, increased perfusion of the right lung. B, improved hypoxemia. C, worsened hypocapnia. D, decreased ventilation of the left lung. Or E, increased AA gradient. What do you guys think? It's a little challenging, it's okay. Physics, kinda, yeah. But think about it. Not B, not C. Okay, not B. Tell me why not B and why not C, Waleed? Why not improved hypoxemia? Why not worsened hypocapnia? Good, okay. Yeah, his O2 is over 60. Also, his respirations are 27 per minute. So his hypocapnia is going to be bad regardless. Doesn't matter if he's lying down or not. It really doesn't matter. It has nothing to do with the fact that he decides to lie down. I want you guys to think about this. If he's lying down, what is changing in this patient? So Faris said D, decreased ventilation of the left lung. Why, Faris? Why do you have decreased ventilation of the left lung if you lie down on your left? I'm leaning to my right. If you're lying down on your left side, how does that affect your ventilation? It's okay if you don't know. Ibrahim is asking me, is it E, lol? Yes, it's E. Okay, so the answer is E because, okay, number one, it's not going to be increased perfusion of the right lung because if you're lying down on your left side, where is all your gravity? Your left side, right? So you're going to have a little less perfusion of your right lung. It's not going to be bad, it's just going to be less. Now, You're not going to have improved hypoxemia. That has nothing to do with you lying down because you don't have pulmonary fibrosis, right? Worsened hypocapnia, we discussed that. That's not going to be the case. Decreased ventilation of the left lung, not really going to be the case. It's not necessarily decreased because he's lying down. You're going to have an increased AA gradient. The AA gradient is your ventilation perfusion, okay? That's what's causing your gradient. So what you're breathing in versus the blood that's basically going to that tissue. So when you're lying down on your left side, more blood is going to be going to that tissue. However, your ventilation, because this patient has what? Like we said, he has pneumonia. So what happens when you have pneumonia? Like somebody tell me literally what's happening in your alveoli when you have pneumonia. Inflammation, good, Momo. Infiltrates in the alveoli, right? Okay, so good. Inflammation infiltrates. You're causing fluid to build up in your alveoli in that lobe. And why? Because of all your like inflammatory cytokines, blah, 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 you have, it's kind of like the same idea as swelling, right? So you'll have all that fluid and all that consolidation. So obviously if you have all that inflammation, how is the oxygen you're breathing in supposed to get to your blood properly, right? Your ventilation is technically not really changing. You're still breathing in the air, like it's still going to your alveoli, but because of all the inflammation, all the fluid that's there, it's not really reaching into your blood as well. And because you're lying down on your left side, you're going to have more blood flow to the left lung because of, simply just because of gravity, right? Physics, like Shema said. So increased AA gradient. Ventilation perfusion. I want you guys to be, as Dr. Atif said, you have to be an expert in this, okay? You guys have to be so good at VQ mismatch and understanding what it is and why it happens. So if A was increased perfusion to the left, it would be right? What do you mean, Shema? I'm sorry, I don't understand the question. Do you mean A, like this one, increased perfusion of the right lung? Technically, yeah. Oh, okay, I understand your question. Okay, so Shema's asking if this said left instead of right, would this be correct? Yeah. Yeah, it would be correct. Absolutely. Okay, so quick recap of a very important concept, VQ mismatch, so ventilation perfusion. V is ventilation, Q is perfusion. VQ mismatch, in its name, mismatch in where lung tissue is ventilated and perfused. So what this basically means is, in certain diseases, you can have increased ventilation. So your breathing is fine. The delivery of oxygen to your alveoli, the delivery of air, period, to your alveoli is fine. However, the perfusion, the blood flow to your lung tissue is not good. You have a VQ mismatch. And a normal, healthy person, inshallah, like all of you, your VQ is not mismatched because you have normal ventilation and normal perfusion. There's like a limit. You don't necessarily need to know the number of limits unless they taught it to you and they want you to know it, right? But for the sake of answering these questions, you don't necessarily need to know the limits, okay? So in you guys, it's normal. In somebody who comes with pneumonia, that is an example of a VQ mismatch, okay? Pneumonia. They have consolidation. They have a lot of inflammation, fluid buildup. Their perfusion is fine. There's nothing stopping the blood from going to that lung tissue, but there is something stopping the air from being delivered directly to your alveoli properly, which is all the consolidation. So you have low ventilation, but your perfusion is perfectly fine. Now, in pulmonary embolism, opposite. You have a blood clot in your pulmonary artery. So if you have a blood clot in your pulmonary artery, you cannot deliver blood to all parts of your lung. So certain lung tissue is not getting perfused. However, your delivery of air to your alveoli is perfectly fine. That is a ventilation perfusion mismatch, where your ventilation is higher than your perfusion. Pneumonia, ventilation is lower than your perfusion. Does that make sense, guys? Is that clear? Clear, okay. Now, emphysema, for example, you have your alveoli are ruptured, some areas are thicker, blah, blah, blah. but technically your perfusion is fine and your ventilation is fine. Your ventilation is not always fine. So that can result in a slight VQ mismatch. So if you look it up, I remember when I looked it up earlier, if you guys look it up, maybe correct me if I'm wrong, it's okay. There is a slight VQ mismatch, but it's not severe like the way you'll see it in pneumonia and in a pulmonary embolism. So over here, you'll see, usually they'll give you radioactive material to breathe in, and then they'll put it in your blood, right? And that's how they'll measure basically your, your ventilation perfusion mismatch. So ventilation, for example, over here is fine and right and left, it's clear. So radioactive material, they can measure it in the air that is breathed in both sides of the lung and almost all lobes. The perfusion in their blood, they've noticed, okay, there's no perfusion here, and there's no perfusion here. There's a little bit missing over here, a little bit missing top over here. So what does this person have in this example image that I brought you here? Good, PE. This is a pulmonary embolism. They're not perfusing blood properly. The only time that will really, really happen is when you have either a vascular issue, and most of the time, in a case like this where they bring up VQ mismatch in this much, like with this much importance, it's going to be a pulmonary embolism. Okay. Now, pulmonary embolism, you can diagnose it this way, but obviously, they probably taught you this in your clinical lectures. You're not going to diagnose pulmonary embolism by like you see a patient and you're like, oh my God, they're breathing really fast. They have sinus tachycardia. You know what? Let's go do a VQ mismatch. By the time you get that all done, your patient's going to be dead. Okay. It's a clinical diagnosis. They're going to have, they're going to be alkalotic. They're going to be alkalotic because they're breathing really fast. Okay. So there's no CO2 remaining in their blood. They're going to have sinus tachycardia. They're going to be in pain. They're going to be diaphoretic. If you see that, and if they have chest pain, immediately PE until proven otherwise, okay? So even in your questions, if you see it, think about PE first, okay? Now, next question. Wait, was that clear, guys? Do you guys want me to repeat anything at all? Clear, alrighty, okay. No, guys, you didn't see that, okay? I hate myself. Okay. I'm so frustrated with myself. Guys, I'm really sorry. Okay, a previously healthy 60-year-old man comes to the physician because of progressively worsening shortness of breath for the past 2 months. He does not experience shortness of breath at rest, occasionally has a dry cough. He does not have a fever, chills, or night sweats. Those are important negatives. He has smoked 1 pack of cigarettes daily for the past 40 years. Bro. He drinks a beer daily and occasionally more on weekends. He does not use illicit drugs. He is 6 feet tall, weighs 66 kg, BMI is 19, his temperature is 37, pulse is 94, respiration is 21, slightly high, blood pressure is 136/88, normal. Lung auscultation reveals a prolonged expiratory phase and end expiratory wheezing. Spirometry shows FEV1, FVC ratio of 62% after bronchodilator inhalation, and FEV1 of 60% of predicted, and a total lung capacity of 125% of the predicted. The diffusion capacity of the lung is decreased. Which of the following is a most likely diagnosis? Ugh, that was so challenging. I know, guys, great job. Okay, you know what? What specific type of obstructive lung disease? Because you guys saw the answer. So what specific type? Damn. Mashallah, guys, good job. Good. Emphysema. Good. Ibrahim said it's emphysema because of the low DLCO, right? Do you guys understand what that means? Like, do you guys understand why? Good. Okay, you guys understand why. Basically, when your alveoli have popped open, you can't deliver carbon monoxide to your blood. You have less surface area. Perfect way to put it. Thank you, Shema. You have less surface area. That is like, if you ever have an SAQ and you need to explain it, use those words, less surface area, okay? So he has COPD. Very clear, he has a decreased FEV1 to FVC ratio. Bronchodilator inhalation does not really improve it that much. If it did, what would your answer be? It would be bronchial asthma. However, if they said it did, if they said it did improve and his DLCO is decreased, you're still gonna stick to like emphysema COPD, okay? Otherwise, in asthma, the DLCO is normal, okay? Because there's nothing wrong with like the surface area. In asthma, your airway is just slightly obstructed because it's narrow. That's it. Is that clear? Good. Okay. Moving on. Your guys' favorite type of question. I know. Okay. A 53-year-old man comes to the physician because of one-day history of fever and chills and severe malaise and cough and yellow-green sputum. He works as a commercial fisherman on Lake Superior. Current medications include metoprolol and warfarin. Temperature is 38.5 degrees Celsius. Pulse is 96 per minute. Respirations are 26. Blood pressure is 98/62. Examination shows increased fremitus and bronchial breath sounds over the right middle lung. An X-ray of the chest shows consolidation of the right upper lobe. Which of the following is the most likely causal pathogen? Okay. Guys, when you answer, I'm going to ask you why you said what you said, okay? Even if it's correct, okay? So don't get scared if I ask you. So, Shaf, you said Legionella. Why? What's your reasoning for Legionella? There's no right or wrong. I'm asking you why you said Legionella. That's all. Like, you guys don't have to worry about. Okay, water contamination. Sure. Okay. Okay, Faris, you said B, Pseudomonas. Why? Sputum. Okay, yellow-green. Ghazi, you said E. What is that? Okay, Legionella. Okay. Walid Ibrahim said J. Okay. Okay, you changed it to J, not E. All right, so the answer, drum roll, is J. Okay? This man just has pneumonia. Lake Superior, green sputum, blah, blah, blah. These are all distractors, okay? So when I was answering this question, I was also thinking, Lake Superior. And the thing is, you have so many options here. What the hell are you supposed to say when you all of a sudden see this? Let's rule out one by one. And this is also kind of like a review for you guys for your like organisms for pneumonia. So TB. He's at Lake Superior. Why would he have TB there? No offense. Like Americans don't really get TB. Okay, not to be racist, but like they just don't get TB. Okay. They could, but usually in the US, it's because of immunocompromise. Okay. Fun fact, by the way, guys, I remember Dr. Atif said this in first year. He was like, TB obviously is like he would say it's like a disease of the East. Okay. So like Middle East, North Africa, South Asia, Southeast Asia, East Asia, we have a problem with TB. Okay. The US never had a problem with TB up until AIDS. Okay. Up until HIV AIDS became a problem there. And then all of a sudden TB started to have chapters and chapters and their own textbooks in the country over there. So if you saw immunocompromised over here in the question stem, definitely think about TB, okay? If you do not, so let's just say if this person is, immunocompromised doesn't necessarily mean that they have to have HIV. Let's just say if the question stem said that this person is on, this person has rheumatoid arthritis and they're taking methotrexate. If you guys remember methotrexate, I don't know if you guys took methotrexate yet in POD or if you guys are going to take it next block and in MSI. Okay, you guys did take methotrexate. Yeah, good. It's a chemo agent. So obviously, what does it cause? Immunocompromise, because you can't make leukocytes, right? So that can be like another example of immunocompromise in your question stem. Don't only look for HIV or certain diseases that are causing immunocompromise. Also think about medications. Always think about medications. Think about people on like high dose corticosteroid treatment for whatever reason it is. Okay, always think about those things. That's when you consider TB. Number 2, Pseudomonas. Pseudomonas, yellow-green sputum, again, is just very typical of bacterial pneumonia. Yes, Ibrahim, it is ventilator-associated, Walid nosocomial, Shayma nosocomial. Good job, guys. The other thing that you want to think about is CF patients, cystic fibrosis patients who have bronchiectasis. If they have a history of CF, if it's a younger patient, let's just say maybe they're like 22 years old or something, they're coming in with pneumonia, they are a known case of CF, Pseudomonas. Okay, that's the first thing you would say. Now the other thing is Fusobacterium. I don't care about that. I'm not even gonna ask about that. I don't even remember, honestly. So Mycoplasma pneumonia, again, atypical. You're gonna have dark pee, maybe. You're gonna have blood breakdown, low hemoglobin. Maybe the person's gonna be more short of breath because of that as well. Legionella, same thing. It's atypical. You might not be able to stain it. They're gonna have hyponatremia. You can do a urine antigen test. Staph aureus, multiple things. But the thing is, again, you're gonna have to be in a case where you're more prone to getting Staph aureus. So for example, you're in a hospital. Hospitals are full of Staph aureus, okay? That's not a typical cause of pneumonia. Drug users, very good. Drug users are more susceptible to getting Staph aureus pneumonia, okay? Strep pyogenes doesn't really cause pneumonia. It causes upper respiratory tract infection, or it causes dermatologic infections, okay? H influenza, again, age of this patient. And the second thing is, it's not the most common cause of pneumonia, okay? But you can keep it like there if you're unsure. Histoplasma is a fungus. Fungal pneumonia presents differently. So dry cough, you're not gonna have green, yellow sputum, so you're not gonna have that. And also if they didn't teach you much about histoplasma, don't worry about it too much, okay? Your only option really at the end is strep pneumonia. When in doubt, if it's a pneumonia question, if you're in doubt, just straight up go for strep pneumonia, okay? It's the most common causative organism of typical pneumonia, okay? That's it. Okay, next question. What? Sorry, guys. Wait, let me just remove that. Okay. All right, okay. So, a 68-year-old man comes to the physician for a routine health maintenance examination. He has increasing shortness of breath and productive cough for the past year. He can walk up a flight of stairs without stopping. He has hypertension and his only medication is amlodipine. What is amlodipine? Calcium channel blocker. Good job. Okay. He has a history of asthma during childhood. He used to work at a shipyard and retired 5 years ago. He smoked 1 pack of cigarettes daily for 30 years, quit 16 years ago. Pulse is 98, fine. Respirations are 25, slightly high. Blood pressure is 134 over 88, slightly high. No. Blood pressure normal in this patient. He's 68, that's normal. Pulse oximetry and room air, 93, so slightly low. Scattered expiratory wheezing and rhonchi are heard throughout both lung fields. Cardiac examination shows no murmurs, rubs, or gallops. Spirometry, FEV1 to FVC ratio is 63. FEV1 is 65% of the predicted. His diffusing capacity for carbon monoxide is 40% of the predicted. Which of the following is the most likely cause of this patient's findings? So this question stem has so many distractors. He's worked in a shipyard, he's smoked, he's had asthma, he's had everything. So productive cough, okay. And he has a productive cough. That could literally mean anything. So over here, understandably, you'd be confused, okay? But your main key question in all of this, ignore all of this. Sure, okay, you know what? You can tell, for example, I'm not going to say this is asbestosis because his FEV1 to FVC ratio is 63, meaning it is decreased, meaning this is not restrictive. So immediately you can take out asbestosis, okay? Now the only ones left really are everything else, which are all obstructive. The only option that's not obstructive over here is congestive heart failure. Could this be the answer? When you look at the thing, it says no murmurs, rubs, or gallops. It's basically asking you to exclude this answer, okay? So it's not congestive heart failure. So now let's look at the rest. Asthma, chronic bronchitis, bronchiectasis, emphysema. There's nothing here telling me that he should have bronchiectasis. Remember, guys, okay, answer this for me. When will the patient have bronchiectasis? Cystic fibrosis, okay, that's one. Has predisposing factors, okay. So bronchiectasis will be cystic fibrosis, malignancy leading to recurrent infection. It will be chronic bronchitis. This patient has infection after infection and has to be treated multiple times. These people are going to have bronchiectasis, okay? Productive cough does not mean necessarily that he's having straight up an infection. It could just mean that he has sputum. Is it clear? Is it whatever color? We have no idea. Now, so you rule out bronchiectasis. There's nothing here to tell me. If he had bronchiectasis, you'd see it earlier in life if he was a CF patient. There is no sign over here that he has malignancy, okay? Maybe if you did a chest x-ray and then you saw like a nodule, then maybe you would think, okay, maybe he has like malignancy, but that's not even in the question. So you're not thinking about that right now. So you've ruled out asbestosis, bronchiectasis, congestive heart failure. Pulmonary hypertension. That's not going to be the case here because they're literally telling you his FEV1 to FVC ratio is decreased. His FEV1 is decreased. It's obstructive. So pulmonary hypertension doesn't fall under that. Okay, so you've taken those out. So now what you have left is asthma, chronic bronchitis, and emphysema. So I want you guys to think about this. Between asthma, chronic bronchitis, and emphysema. Good, Shema. So DLCO is low. What does that mean? Emphysema. Good. So the answer is emphysema. Now, your main thing over here is DLCO is 40% of the predicted. If you see a percentage like this and it's blah, blah, blah of the predicted, imagine the predicted is like 100%. Obviously, 40% is low. So DLCO is low. This is just like a fancy way of saying DLCO is low. DLCO being low means there's a problem with the surface area with the diffusion, right? So that will happen either in restrictive lung diseases or in the one obstructive lung disease that causes low DLCO. And over here, if you're thinking, okay, low DLCO, it's restrictive. Wait, no. FEV1 to FVC ratio is low over here. FEV1 is low over here. Faris, is there a normal value of DLCO? Yes, there's a normal range. I don't know it, and neither you don't have to know it either. Not even for step one, not in the hospital. You don't really need. In the hospital, only the pulmonologists are going to know it. Okay, so you don't have to know it at your stage. Is that okay? Okay. The reason it's not chronic bronchitis is, again, you're going to have, sure, productive cough, but you're going to have a more clear history of, okay, chronic bronchitis, again, the diagnosis is made. What is like the criteria? How many months, how many years? For a longer time. Yes, Momo. 3 months for 2 years. Good job. So you didn't see that in this question. So you can't say chronic bronchitis for sure. And again, final thing, DLCO is low. 40% of the predicted, you're going to go straight for emphysema. If it's low and this is giving, if it's giving obstructive, you're going to go for emphysema. If it's giving restrictive, you're going to go for a restrictive lung disease. Okay. Faris, but how will I say that it is low? In your exam, they will tell you it's low, or they will tell you something like 40% of the predicted, and then they're going to give you like in the lab values or in the values that you have to know, like the actual value. If you're interested in knowing the actual value, you can always Google it before your exam, but I'm telling you, you don't need to know it. If they didn't stress on it in your clinical lectures, you don't need to know it. What you guys need to know at your level is, why is this important and what does it mean? If it's low, what does it mean? If it's normal, what does it mean? That's all you need to know, okay? I hope that answers your question. This is a nice little like algorithm or table, if like, you know, if you want to call it that, to basically get to your diagnosis. So you do your pulmonary function testing. If it's greater than 70% or 0.7, FVC is it's gonna give like a restrictive picture. Okay, FVC is greater than 80% of the predicted, yes, you're gonna measure the DLCO. Okay, if it's normal, person's healthy, it's okay. This 80% doesn't really mean much. If it's decreased, it can be decreased for a number of reasons. If it's increased, it can be for a number of reasons, like pregnancy, pulmonary hemorrhage, polycythemia. I don't think you need to know all of these specific things. The main things you guys need to remember are like, okay, if it's obstructive and the DLCO is low, emphysema. If it's increased, it can be any of these things, but these are not really like pulmonary or cardiac causes, so they're not going to focus in on them for CVP. Okay, but this table is generally good to know for step one, in the future, and for you to know basically for the hospital. You don't have to have this memorized. I don't have this memorized. I don't have to have it memorized, but this is just good for your own knowledge, okay? Just like basically, I would highly, highly suggest looking at this and reading it before, like the night before your exam or like a few days before, just to kind of understand like, okay, pulmonary function tests will give me this picture. If it's, for example, below 70%, what does it mean? Blah, blah, blah. Okay, if it's below 70%, it's giving an obstructive picture. Now, is the forced vital capacity high? Yes, it's obstructive. Is it not? It can be a mixed lung disease, and you guys maybe learned about that, but they're not usually focused on. Is it now, on the other hand, if the FEV1 to FVC ratio is greater than 70, obviously it's giving a restrictive picture. Is the forced vital capacity greater than 80% of the predicted? No. Is the total lung capacity greater than 80% of the predicted? No, it's a restrictive lung disease. Because remember, TLC in restrictive lung diseases is low, okay? If the FVC is greater than 80%, then you want to measure the DLCO. Because if it is not greater than 80%, then you know, okay, this is giving a restrictive picture. Let's just make sure, let's measure the total lung capacity. Is it greater than 80%? No, restrictive. And then now you measure the DLCO to tell you further. Is it greater than 75% of the predicted? This is most likely a chest wall or neuromuscular disorder. Okay, if it's less than 75% of the predicted, it is an interstitial lung disease. Okay, and then over here, usually it's going to be in percentages, not actual numbers. It's going to be in percentages. So over here, you can tell what's mild, moderate, severe. Now, again, you don't have to have this memorized, but this is going to give you a very, very clear picture of like when the DLCO is increased, decreased, and normal, and when and where, and when it's applicable and when it's not. Okay? Is that clear to you guys? I kept this here for you guys to read later because we do have a few more questions I want to answer, and I don't want to go too much into detail about this. I kind of did, but yeah. All right. Okay. Now, these are your last two questions, okay? They're both cough, and the reason I wanted to keep these is because everybody and their mother and father comes to the hospital with a cough, and it can literally mean anything, okay? So these are two really good examples of differentiating, for example, like extrapulmonary or extracardiac causes versus pulmonary or cardiac causes, okay? So let's get into it. A 66-year-old woman comes to the physician because of a 1-month history of episodic cough. She reports that the cough is non-productive and is worse when she lays down. She has smoked half a pack of cigarettes daily for 25 years. She has hypertension and coronary artery disease. Her current medications include losartan, aspirin, and pravastatin. What is losartan? ARB, good, okay. Her temperature is 37.3, pulse is 84, respirations are 21, blood pressure is 144 over 85. So nothing super, super alarming. 144 is slightly high, that's it. Pulse oximetry on room air shows an oxygen saturation of 94%. The pulmonary examination shows mild bibasilar crackles. Cardiac examination shows an S3 gallop. Spirometry shows an FEV1 to FVC ratio of 88% and an FEV1 of 90%. The DLCO is decreased. What is the answer? Basically, determine the cause of cough. Sorry, there's like no end question, but determine the cause of cough. So, 66, 1-month history of episodic cough. She reports that the cough is non-productive and it's worse when she lays down. She smoked, she has hypertension and coronary artery disease, S3 gallop. Spirometry shows FEV1, FVC ratio is increased, the FEV1 is increased, the DLCO is decreased. Okay, so a lot of you are saying H. Does anyone have any other answer? Sorry guys, my screen is, okay. All right, okay. I know it's a lot of It's a lot of options. So let's walk through it, okay? Because I don't want to show you guys the answer yet. I want us to work through it together. Okay. So number 1, emphysema. Possible, but why would you not say emphysema? Let's rule it out one by one. Ratio, good. Okay, very good. Ratios increase. So emphysema, you're not going to see that. It's not a restrictive lung disease. Upper airway cough syndrome. Yes or no? No. Good. Okay. No. Why? Upper respiratory tract. And also, if this were the case, it would maybe give more of an obstructive picture, and that's not the case here, right? Now, GERD. What is GERD associated with? Which pulmonary condition? Asthma. Good. So asthma, would that have the same FEV1 to FVC ratio that you see here? No, exactly. You would have an obstructive picture. So you would have a low FEV1 to FVC ratio. Infectious pneumonia. Why or why not? Like, why yes or why no? No. Okay, good. Why not? No fever. Good. And also, it's been month episodic. That could be atypical, but it's very unlikely. She's not had a fever. She's not complained of any other symptoms. So, no. And atypical, again, you would see maybe symptoms of hyponatremia. Or, in the lab, in the question, it would tell you that there's hyponatremia. Or you would see, oh, the patient is complaining of dark urine. They're short of breath more often because they're anemic, right? Which would be like mycoplasma pneumonia. Now, moving on. Hypersensitivity pneumonitis. Why or why not? No allergens. Good. There's nothing telling you, like, she doesn't have birds. She's not working in a job where, there's like silica or asbestos or coal, all that stuff, right? Bronchial asthma. We said why not, right? And again, guys, another thing, this is another example. You see GERD and you see asthma, both as options in the same question. If they're too similar to each other, it's going to be neither of them, okay? Because these two things are associated with each other. So you're not going to pick them together, okay? Medication adverse effect. Is there anything over here that would be causing her to cough so much? It literally says losartan. Like, they're literally telling you, like, hey, it's not a medication adverse effect because she's not even on an ACE inhibitor, okay? Pulmonary fibrosis. Maybe. Very much so, maybe, yeah. Lung cancer. Why yes or why no? No constitutional symptoms. Good. Very good. In lung cancer, literally in every lung cancer, you're going to see, if you don't see constitutional symptoms, you're going to see, oh, I'm having shoulder pain and it's a Pancoast tumor. Or you're going to see something that's like an incidental finding and it's like a pulmonary hamartoma. Okay? Stuff like that. It's usually going to be incidental metastases or hamartoma, or it's going to be constitutional symptoms. Or again, for example, if it's a carcinoid tumor, you're going to have diarrhea, flushing, all that jazz, serotonin syndrome like symptoms, okay? So rule that out. Congestive heart failure. Yes or no? Why not? Good. Ratio is affected and she has a cough. So it's not really like her pulmonary function test would not really change that much just based off of congestive heart failure, right? Chronic bronchitis, immediately rule out because it has an obstructive picture. This question is not obstructive. This is very clearly restrictive in nature in terms of her spirometry. If you see this question, you could definitely appeal it and they could accept both. But over here, because this is AMBOSS, and obviously I'm not going to appeal a question on AMBOSS because they're right and I'm wrong. The main thing that you have to look at is S3 Gallop, right? That I think is like the thing that they want you to focus on here. I can't find the question now, but I had it earlier. And if I find it, I will send the explanations to you guys and you guys may be able to find it yourself, but I will look for it. Now we're able to rule out the other ones because of what we discussed, right? So this is obviously not giving an obstructive picture. So the only two that you're really going to be left with is congestive heart failure and pulmonary fibrosis, okay? Now the reason that it's congestive heart failure is, and it's causing, for example, a restrictive picture in the spirometry, you can have, due to congestion, you can have backflow of blood into the lungs, and that can give you a restrictive picture just because of fibrosis, or let's just say she has fibrosis and it's causing cor pulmonale, and she has right-sided heart failure as a result later. This is a tough question. Hence, I also got it wrong with you guys. It's okay. But if you see a question like this, obviously, if you see S3 gallop, I think the safest thing would be to go for congestive heart failure. Okay, even if you see the spirometry results. But if you answer pulmonary fibrosis, that is also understandable as to why. Because the thing is, sometimes in pulmonary fibrosis, you have a non-productive cough. In congestive heart failure, you can have both a productive and non-productive cough, which is confusing because typically in congestive heart failure, you could have a productive cough of clear sputum because of, fluid excess in your lungs due to congestive heart failure. So this is a harder question. I am really sorry. I will find the, I think if I'm not wrong, by the way, this was a 4 or 5 hammer question, but I will find the explanation for you guys. I'm really sorry about that. And I will send it to you guys, okay? Once I find it. So do you guys have any questions about this that I can answer before I send you guys the explanation later? I'm sorry about that, by the way. Is there anything that, you guys want to touch over besides these two options in the question? Anything else? Also, I'm sorry for swearing. That's so inappropriate of me. Okay. I'm going to take that as a no. We're going to move on. Okay. Next question. Also cough patient. 68-year-old man comes to the physician because of a 4-month history of episodic cough. He reports that the cough is non-productive and is worse at night and when he walks to buy groceries. He has not had chest pain, hemoptysis, palpitations, or heartburn. He smoked 1 pack of cigarettes daily for 30 years, but quit 8 years ago when his granddaughter was born. He has hypertension and osteoarthritis of the right hip. Current medications include hydrochlorothiazide and celecoxib. His temperature is 37.1, pulse is 71, respirations are 19, and blood pressure is 139/85. Pulse oximetry on room air shows an oxygen saturation 97%. Pulmonary examination shows diffuse and expiratory wheezing. Cardiac examination shows no murmurs, rubs, or gallops. Spirometry shows an FEV1 to FVC ratio of 60% and an FEV1 of 65%. The diffusion capacity of the lung is normal. So, one by one. Okay, A, emphysema. Yes or no? If you guys feel like you know the answer, you can put in the answer. No. Okay, good. DLCO is normal. Upper airway cough syndrome. No. Good. GERD. GERD, yes or no? No. Okay, yeah, good. GERD itself would not cause these things, but it could possibly, for example, when it's associated with asthma, sure, but then the question should ask you about association. It shouldn't be directly about, oh, hey, by the way, yeah, it's a GERD based off of a spirometry test. There's obviously going to be other things like epigastric pain, etc., blah, 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 okay? Infectious pneumonia, yes or no? No. 4 months, episodic cough, he would have a more acute presentation. Not necessarily if it's atypical, but a more acute presentation. His cough is non-productive and it's typically worse at night when he walks to buy groceries. So that should, be an indicator this is not pneumonia. It's not an infectious cause either. Also, his temperature is normal, semi-normal. 37.1 is considered normal. Bronchial asthma. Or sorry, hypersensitivity pneumonitis. No, there's no allergens. Bronchial asthma. Maybe, it could be. Shema, why no for bronchial asthma? Why do you say no? Can it start suddenly? Symptom onset can be sudden, yeah. Even if it's your first time getting asthma, yes, it can. But typically, for example, it'll happen, you'll ignore it for a while, it'll happen again, you'll ignore it. And then once it keeps happening, then you'll go to the doctor and be like, hey, I'm having these symptoms. And it's not necessarily like starting suddenly. But yes, asthma symptoms definitely can start suddenly. It can happen due to like bronchoconstriction that happens very quickly or suddenly. Yeah, definitely. So let's just keep that as a maybe. Medication adverse effect. Is there anything over here that causes airway constriction or anything? No, not really, right? Pulmonary fibrosis. No. Why? Spirometry shows an obstructive picture, does not show a restrictive picture. Lung cancer, like Ibrahim said before, no, like there's no constitutional symptoms. He's not complaining of weight loss. Sure, he's been smoking a while, but that's not enough to tell you that yes, this is cancer, because smoking causes every single problem. Congestive heart failure. Sorry, guys. Wallah, I'm really sorry about that. Not again. No, obviously it's not going to be the answer again. And also, it's not really the picture here, right? Sure, he's coughing, but like, he's not having an S3 gallop, right? And he's wheezing. So chronic bronchitis. What would you want to see in chronic bronchitis? Like we said, there's like the criteria, right? 3 months for 2 years. Over here, he's had a 4-month history of an episodic cough, and he says it's worse at night. That's not going to happen in chronic bronchitis. Chronic bronchitis is going to be bad the entire day. Like you're going to be complaining about it the entire day, not only at night. Okay, bronchiectasis. Like we said, you have to have a lot of there's like predisposing factors. There's other things that cause it. So the answer is bronchial asthma. Okay, DLCO is normal. Spirometry is showing an obstructive pattern. So what do you call it? That should tell you, okay, this is obstructive. But this person, worse at night, worse when he walks. So it's exacerbated by exertion. And exertion can be anything. It can be walking. It can be sports. It can be anything. At his age, 68, the exertion might be, lighter than what it might be for some people our age. It might just be walking for an older person. So bronchial asthma is the answer here. Okay, is that clear? What made me think of lung cancer is that it is sudden. Can it be though? Lung cancer, yeah, like your symptoms can also start suddenly in lung cancer, but the thing is, the first thing you will think of is not lung cancer in a patient like this. They're not having weight loss. Sure, they've been smoking for a long time. Sure, their onset is kind of sudden and like, continuous after that. But it's with exertion. It's more at night. Now, if your tumor is placed in a specific area, for example, if it's causing like airway obstruction, maybe. But the thing is, it's going to be insidious. It's not going to be sudden. Okay? More symptoms typically for cancer, more symptoms are going to be provided. They're not going to expect that to be, guys, cancer will never ever be your first diagnosis in any patient you ever come across. So even keep that in mind with questions. Cancer will never ever be your very first diagnosis unless this person is having constitutional symptoms, so fever, weight loss, all that jazz. Then you're going to think about, okay, maybe this is cancer, but then again, you have to think about infection. You have to think about autoimmune disease. You have to think about a lot of things. So cancer is never your first like thing that you're going to be like, oh, okay, this person smokes. He's having an issue now, cancer. And it's never going to be off the timeline either. Timeline can give you a very big hint. This might be cancer, but not the primary diagnosis. So even like in this patient, the first diagnosis is, oh, this patient has asthmatic symptoms, right? Like I'm telling you guys this, like even clinically, for example, like in the hospital, because I've been working in the emergency room for the past few weeks now. Any patient that comes in with a cough, okay, do you have any chronic diseases that you know of? Like, do you have asthma? Do you have a history of infections? Is there cancer in your family? Blah, blah, blah. But you're never going to go to cancer immediately. Have you had weight loss? Yes. Have you had some fever? Yes. It could be infection still. You do a sputum culture. Cytology, maybe if you're suspecting cancer. So all of those things. So in a patient with a cough like this, if you're seeing an obstructive pattern, DLCO is normal. Exertion, go for asthma. It's basically asthma until proven otherwise. Then you could do like a methacholine challenge test. If they have improvement after they take bronchodilators, it's asthma. If they don't have much improvement, it's another obstructive lung disease, and you can do further testing to find out which one. Okay, so there are steps to it. So does that make sense to you guys? Awesome. Okay. That is it. That ran a little longer than I intended for it to, but I really, really hope it was helpful. I'm really sorry about that one question. I'm gonna look for it. I just have to open up my history and see where it went because I can't find it right now. But do you guys have any questions about the exam in general or anything that we discussed? You guys can unmute. You guys have 4 days left. I want you guys to know that is plenty of time to do questions and do well and be able to cover material you haven't covered yet. So don't worry about it. My one piece of advice as of now, and you guys probably already know this, is even if you have not covered every single thing, do not skip on questions. Start questions now while you take the time sometimes to cover those things that you haven't covered, okay? Now, in Al-Faisal, they like to focus on certain low yield things, especially Dr. Hatouf, Dr. Abrar. They like their details. Dr. Mohabbat can sometimes focus on low yield, but I've noticed her questions, at least, you know what, at least they're more explicitly stated on her slides. Dr. Abrar as well. For him, definitely do Robin's patho review. It's definitely in your compiled questions. Definitely do the UWorld questions. The AMBOSS questions are great for practice. Get them wrong and then get them right after, like we did. And just remember, the most logical answer that comes to your brain first is the most likely answer. And if it's wrong, it's okay. It's one question. And if there's like a very obvious thing, for example, in that question, like in this one, I think you're gonna just want to focus on S3 Gallop, and maybe that's the final giveaway. But when I was doing this question, I remember I answered it correctly. That's the thing. And I think it's just because bibasilar cracks, Eman, bibasilar crackles and S3 Gallop. Maybe that should have been enough. But this spirometry can be very, like, it can throw you off very easily. So I understand why, for example, even I with you guys said pulmonary fibrosis. So just keep in mind, like, whatever is more obvious to you in that moment, choose that answer. The answer that comes to your brain first is the correct answer, okay? Don't doubt yourself. It's going to be a good exam, inshallah, but just practice a lot of questions, okay? For your OSPE, be good at X-ray imaging and be good at the histopathology for the tumors, because they will ask you about that. Be good with the pneumonia treatments as well, and like agar, and like, oh, they show you charcoal yeast agar, and that's all it is. What is the cause? Legionella. What else will you find in this patient? Maybe that might be the question. Hyponatremia. So you guys just need to know like the few bullet points for like everything. And if you know those bullet points, you're going to be able to answer any question. Do you guys have any questions at all? Literally any at all, like about anything. It can even be about cardio if you want, like anything at all. All right, I don't think you guys have any questions. Resources review from Pathoma, very high yield, UWorld, the questions, and compiled questions, okay? Oh, plus past exams. I put it out in case any doctor sees this, but yeah, either way, they're probably not gonna, it doesn't matter, they know they exist. This is my email, my number, and if you want to DM me, feel free to anytime, any question, anytime. Please don't feel shy. I will answer as soon as I can, okay? So that's pretty much it. I will add in the notes and I will find that one question for you guys and I will put them into the PowerPoint before I share it with you. I know it's a lot of slides, but a lot of them again are just like the question with the answer. That's it, okay? Thank you guys so much, and thank you for being patient with me as well, and I really, really hope it helped. If there's anything else I can help you guys with, please do let me know, okay? Best of luck. You guys are gonna do amazing, so don't even worry about it. Don't call me doctor. I got a few months left. All right, yalla, see you guys.